Okay, everybody, I'm just going to get started with the housekeeping so that we can get started on time for tonight. First of all, I'd like to welcome you all to tonight's webinar. We really appreciate you giving up your time to join us. I'd like to start by recognising that I'm hosting the webinar from the country of the Bundjalung people. I'd also like to recognise the traditional owners of the countries where you are all attending tonight, and I pay my respects to all elders past, present and emerging. This meeting has been approved for one reviewing performance hour with the RACGP. If you are with the RACGP, we will submit those hours directly to the college on your behalf following the webinar. If you're a member of ACRM or another CPD home, we can arrange for a certificate to be sent to you so you can claim your hours with your particular CPD home. A feedback form will be emailed to you directly following the meeting, which can be completed online. Please do take the time to fill that out, as we greatly value your feedback for planning our future activities. Please ensure that you do have access to the worksheets. Those were sent out prior to the meeting, and I have linked those again in the chat in Zoom. You will need to go through those worksheets as part of this session, so please make sure that you have access to those. It will be quite a fast-paced webinar tonight. Anita has a lot to get through, so we would suggest, if you have the facility, to print those and complete them by hand. If not, you can write on a piece of paper and fill out the worksheets later on. There are some online options there if you have a second screen or a second device, or you're very tech savvy. There are links there to complete them directly online and just submit them straight in as well. So also, as we go along, if you have any questions, please type them into the chat window in Zoom, and we will try to address them as we can. So I would like to introduce our presenter for tonight, Dr. Anita Munoz. Anita has worked as a clinical editor and clinical advisor for 6 years with Northwestern Melbourne PHN, through which a passion for health system improvement, innovation, sustainability and equity emerged. She sees general practice as the key to a rational health system that produces better outcomes for patients and practitioners alike. Anita is a GP in private practice in Melbourne CPD and has a dedication to evidence-based medicine, lifelong learning and promoting the role of general practice in the health of patients, communities and in public health more broadly. She has held advisory positions with Better Care Victoria and Safe Care Victoria and has been a medical educator for over 9 years. She's particularly preoccupied with the wellbeing and experience of general practitioner registrars and is securing a high-quality general practice workforce for the future. So, Anita, if you are ready, I would very much like to hand over to you.
Thank you very much. Thank you for inviting me, and thank you to everyone who's joined online. I'm just going to get things started here. And I presume that you're all able to see these slides. Let me know if you can't. So as Nicole has said, there's quite a lot to get through. So I am going to go at a fast pace. But what I'm going to suggest, just so that we can all get the most out of how we get through to tonight, is if you can start trying to answer questions that I'm going to pose throughout this webinar. And if you can put them into the chat if you've got the time and the dexterity to write your answers, and perhaps put some of your answers into the chat, because that can help other people to develop their thinking and get a sense of what everybody else is thinking when it comes to making recommendations for travel vaccines. Because what we're really going to be focusing on tonight is talking about travel vaccinations, and we're going to do some pretty common travel destinations that GPs around Australia encounter, and are really wanting to focus on getting the advice about vaccines as honed as we possibly can, including what products are available on the market and what are the dosing regimens. Because as with all things in medicine, the devil's in the detail. So you've got to recommend, but then you've also got to execute dosing regimens. I think, and this is a big part of tonight, is that in order to get people to accept the need for a vaccination, I think we need to actually explain what is the disease that we're trying to prevent. And so when we're working our way through this webinar, I am going to have just a very high-level way of describing a disease to patients. so that they understand what is the importance of the vaccine, because a lot of the terms we use in medicine are kind of meaningless. And so being able to have a spiel ready in order to explain to patients what the disease is we're trying to prevent puts the use of the vaccine into greater context. So I'm going to invite you to maybe consider what you would say to a patient about a disease when you're about to then launch into the utility of its associated vaccine. I also want us to think about the context of travel, and we give nuanced advice, particularly about the countries that people travel into, but also the activities they're going to undertake, the regions within countries that they're going to visit, the duration of the stay, and also the seasonality. So we know that some diseases are more likely to be transmitted in certain seasons. And so all of those things need to be considered. And I think while you're going through this, it's an opportunity to think, well, this is what I'm currently doing now. When I go to work tomorrow, are there things that I'm going to be doing differently as a result of this? And the reason I point that out is that's the basic premise behind the reviewing performance component of our new CPD. So we're going to go through two cases, and the cases are going to start off with a trip to Bali, which seems like it's straightforward, but I can assure you it's often not. And then we're going to follow a family that's going to go home to India to visit their family. So think about explaining these infectious diseases, the vaccinations you want to recommend, and then how you're actually going to be rational about drawing up a vaccine regimen. In order to get the reviewing performance part of this, really your participation here is reviewing performance, but it is a very good idea to keep a record of the things that you do in CPD. And so I would suggest that you use the prompts that we provided and your answers to questions, and then you'll be able to go back and look at things you might want to do differently at the end of this webinar. So I'm going to launch straight into this. And so we're going to meet a family called the Singh family. Now, this is a 4-person family. They've come in because they're going to go to Bali in 6 weeks' time. They're going to be spending 3 weeks in Bali. Some of that time will be beachside and some will be in a mountainous area. We know that the Balinese rainy season finished 2 months ago. And so the family wants some advice about what they're going to need in terms of travel vaccinations. I'm not going to have time to go through all of the other kind of travel advice and travel kit and all those other precautions we normally go through. So just to remind everyone, we're really only talking vaccinations tonight, and I do not want to suggest that travel is only about vaccinations. But these topics are big, so we're going to hone in on vaccination just for tonight. There are 4 members of the family. Nikita, who is the father, he's 34 and he is insulin requiring because he has diabetes. Priya, mum, is 33. She's well. She's contracepted. She has a young child, Prasant, but she is not breastfeeding anymore. And she mentions that she's had dengue fever about 8 years ago. Bindia is the daughter of the family. She's age 6 and she's well. And then little Prasant is a year old. Now, the Singh family arrived in Australia 4 years ago. So we know that Nikita, Priya and Bindia were all born overseas, and so they've done some of the vaccinations overseas. Prasant was born in Australia and he's been tracking with the Australian NIP so far. So when it comes to COVID, both the parents have been vaccinated against COVID, and that's a year ago now. Priya has had 3 doses and Nikita has had 4 doses. The children have done they're as up to date as they can be for their ages. Prior to this, we don't have total certainty about the vaccine history because the family they don't have access to the vaccine history from India, and then a little bit wobbly on what they've had and when. And we've got 6 weeks to sort this out. So that's the essential premise for this consultation, and there's going to be a lot of work going. You've got 4 people to think about. And so the first thing that I always ask myself when I'm doing a consultation like this is, what am I going to use to get my information as accurate as possible? And so I'd invite you, if you can, to perhaps type into the chat or write down on your forms if there are particular go-to resources that you use. We know that there are many resources around. Some of them are behind paywalls and others are free. And I think one of the things to really get used to is using a website that you trust and using it very effectively and being able to navigate it very well. So we've got a lot of people saying CDC, and that's totally acceptable. We know it is American-based. We also know that there's best practice, and that's got some travel information. Smart Traveller, of course, has got good information. That's the Australian government website. I tend to avoid just the Google, unless the Google is sending me to a trusted website. I personally, I work in a travel clinic, and we do a lot of this. And so we have access via registration to the Shoreland Travax website. And I do commend that to people who are going to do a lot of travel medicine. It's very up to date, and it gives you warnings about things that are going on around the world. And I find that it gives very accurate information. Whatever resource you're going to use, I think as long as it's well thought out and there's familiarity, then you can navigate around your information pretty quickly, and try to only use reputable evidence-based websites or resources is the essential message here. So we've looked up our destinations, and you think, what vaccine preventable diseases am I actually going to work on when it comes to this family's trip to Bali? And there are different ways that you can answer this. You could talk about every single disease that a person can contract in Bali that is vaccine preventable. You can also think about the kind of conditions that I absolutely positively must protect this person from. And then there are other vaccines that are that I would consider. They're not totally mandatory, and they are context-based. So have a think and perhaps put down onto your sheets what you definitely want to vaccinate this family against and what you're going to consider talking to them about. And I agree with Say, who's just said that they use the AIR, and I think absolutely the AIR is a fantastic resource because often the lost information has been perfectly well stored in our AIR resource. So we've got some really good results here, and I agree with a lot of the responses that you guys have put in, and we're going to go through some of those now. So this is what I've come up with using my resources, and I kind of divide the discussion up into the things that I know I absolutely want all the people of this family to be protected against, and then there are other things where they may or may not need the vaccine for different reasons, or I might need to base my advice on a risk profile depending on the details of the travel that they're going to do. And so that's how I've divided up this discussion with the Singh family. When I think about Bali, when I think about Southeast Asia, and I think about South America and Africa, everyone I want to be hepatitis A and typhoid immune, and influenza is a given. And then I work my way methodically through the others. So we're going to do that now. And my first question for you is, if you're going to be talking about hepatitis A, how do you describe what hepatitis A is? So have a think. If you've got to give a couple of sentences, how are you going to explain to a family what hepatitis A is so that they understand what is the purpose for being vaccinated? And I can just let some of our participants know, actually, yes, there is a vaccine for dengue fever, but its use has very, very limited reasons why you'd use it. So we actually will go through dengue when we get to that part of this conversation. So if we think about working our way through this conundrum, we've got to decide for all of the people of this family who gets what, and how do I justify what I'm about to give each member of the family, because they're all slightly different. So the starting point I started with hepatitis A, probably because it starts with an A. You've got to start somewhere. And the first thing I'd explain is what actually hepatitis A is. And I think that a lot of these responses that you're giving are really good. It's something that you ingest. And so it's a virus that attacks the liver, and you can be not bothered by it, and then you can end up in hospital with it. And we're really talking about food and water contamination. And unfortunately, it is really easy to catch. And it's one of those viruses that does pretty well on its own in the environment. So it's a hardy virus, as opposed to things like HIV, which just collapses and dies when it sees soap, for example. There are some other viruses that are better designed to exist in the environment. So the family says, okay, well, that sounds important. We're not keen on contracting hepatitis A, which is very wise. So you've got to decide who's going to get what. So maybe just using your sheets, or you could just, in the interests of time, you could just say, mum, dad, boy, girl, to help with keeping up with the pace. And I do apologise for the pace that we're going. But you can think about, well, I've got 2 kids, I've got 2 parents, I've got 3 people who were born and raised in India. How am I going to work my way through this? And so the answer, as far as I'm concerned, is going to look a bit like this. You would give a vaccine to anyone in this family who you thought wasn't immune. So you can answer that question in different ways. For example, Bindya, Priya and Nikita, if they followed the Indian schedule, are going to have had hepatitis A as part of the Indian schedule. The reason I know that is because I've looked it up. I actually do see a really large Indian community. I work in Melbourne. There is a big community in the CBD. I happen to know that, but I look it up. But if the family is really unsure, then this would be a scenario in which you could do some immunity, do your serology so that you can check. If you think, well, the family doesn't really care whether they know or they don't know, they're immune or they're not immune, they just want to be boosted, you could do that too, because you're not going to overdose these family members, Bindya, Priya and Nikita, on hepatitis A. So you could just give the vaccine, or you could check immunity and then give the vaccine, given that there is a cost involved. So you'd be negotiating with the family. We know that Prasanth has not had hepatitis A. It's not on the Australian schedule. And so he needs some protection. And so what we're going to do is make a decision for the 3 older people. We're going to vaccinate or not, or we're going to use the immunity to give us a more accurate picture of things. And then we know that Prasanth definitely is going to need some protection. And so once you've arrived at that part of your thinking, the next thing you've got to decide is what product and how many doses does everybody need. So think about, do you have these products in your fridges? Do you write scripts, and do patients get the scripts and bring them back? What are some of the processes for when patients come in, if they're returning with a script, who actually delivers the vaccine? And so then you can move through the logistics of this. I work in a travel consult. I just go up the hall, I go to the fridge, I bring back whatever product we have. We will talk about the combination of typhoid and hepatitis A, because it's a ripper of a combination. It really reduces the injection burden, and we would offer that as an option. And Catherine is saying, if Bindya is needle phobic, and we do know that there are lots of kids who are needle phobic, she may want to test serology, although when you're testing serology, you're exposed to another needle. And so you've got to decide with the parents and with the child what's going to be best for her. Now, I do agree with Viraj, who's saying you're probably going to discuss typhoid at the same time as hepatitis A, and I do agree with that, because then you can offer the vaccines together. But I have chosen in this webinar to go by disease state, because there are so many different ways that you can deliver these vaccines. I had to have a starting point, and the starting point is who gets what. But absolutely, I think it's important to recognise that where you can, put vaccines together in the same vial to reduce the injection burden if possible. So when it comes to hepatitis A, these are what your options look like. And I'm actually not going to suggest that after a while, when you've been doing this for a while, it just becomes part of your mind palace, as it were, and you just remember all this stuff. But I think it's actually very reasonable to have a use and aid memoir for this, and particularly because some of the products become more or less available because of the market and what's going on internationally. So if you're not totally sure, do look it up so you don't get your products wrong, because we've got the issue of a child here, for example, who is aged only 1. And so when you look at this information here, if we are going to vaccinate Prasanth, we've got just the Vacta pediatric product that's going to be suitable for him. For the other members of the family, they can use other options, but Prasanth is 1, so he's really got 1 option. And this is if we are just sticking with hepatitis A alone. When it comes to combinations, then that does limit things a little bit for Prasanth. But these are what you're looking at in terms of your options to offer each member of the family. Let me move on. We're going to, and I will circle back a bit on the combination with typhoid when I get to typhoid. I think I've used the same hepatitis A brand for both doses in the schedule. It's not totally mandated. Beg your pardon. I'm just going to move forward here. It's not totally mandated. I think it is helpful if you can do so. But for example, you could, if you've got an adult, start with one and finish with the other. It does depend a bit on what is available in the market, but where possible, if you can continue with the same product, that is preferable. Bearing in mind, for example, some very important distinctions, like you've got less time to finish the dosing interval with something like Vacta compared to the other options on the list. I'm not going to spend a lot of time on influenza because I think that the one thing that GPs do extremely well is influenza. And so I don't want to teach anyone online here to suck eggs, but I guess one of the things I really do want to point out here is, first of all, as we know, influenza can be an absolute disaster. And we've got little Prasanth, and he's still really just a baby. And we've got Dad, he's got diabetes. But also, when people are traveling, their exposure to influenza can really go up during the travel process. So they're going to be on an airplane, they're going to be in airports, they're going into other seasons. And so even our traditional thinking in Australia, like our season has come to its end, doesn't necessarily apply to the traveller. So I'm always very interested in people who are travelling so that we can make sure that they are protected from influenza. And as we know, people die every year from influenza in Australia alone. When it comes to who's going to get what, well, I'll ask you to sort of fill in your sheets, whether you're going to do mum, dad, boy, girl, or whether you're going to single out members of the family. I just ask you to think that through for a couple of seconds, because I'm going to tell you what I think is important for this family going to Bali for 3 weeks, and what my answer to this and what the guidelines really suggest is the answer is a resounding yes. Protect these travellers from influenza. Antonio, I'm so with you on this. Now, I don't want to tell you all about influenza vaccination because we do this day in, day out, but I do want to draw attention to little Prasanth, because there is that concept of how many doses do you need when you're a child. And we would have to ask the family, has he already started with his influenza journey? He's actually 1. He's over the age of 9 months now. So if he was sort of 6 to 9 months, you'd be wanting to do the 2 doses in a row. Whereas with Prasanth now, he's aged 1. He'd be starting with his normal influenza vaccines, and then he'd be doing them yearly. But I would be very reluctant for any of these family members to go overseas without influenza protection. I'm going to move on now to typhoid. And before I go on to typhoid, I just ask you to reflect, how are you going to explain typhoid to this family when they say, well, what is it and why should we care? I think, yeah, that's right, Pushpa. I think that you're right. We need the pediatric dose of influenza for Prasanth. Bindia's now over 5. She's getting the usual dose. So yeah, typhoid, it can be a very serious infection. And it can range from not too bad, like a lot of these things, to actually a bit of a catastrophe. And the reason for that is you can get complications where you get that dreaded, bleeding from the bowel, perforation, encephalitis. And unfortunately, it really is contaminated food and water. We don't really have a typhoid problem here in Australia. And in fact, most typhoid that we see is in the return traveller. That's one of those famous fever in a return traveller consults. So it can be a totally trip-destroying episode. I have had a friend of mine who ended up in hospital in Bali with her baby, who was in hospital, both with typhoid some years ago. So it can be a very nasty a condition to get. So protection, I think, is better than cure, of course. And I do apologise that I don't have time to go through all of the food safety, etc., that we would normally do. I'm just going to focus here on the vaccinations. So when we look at this, who's going to get what? We've got 3 people who were vaccinated up to 4 years ago in the Indian system. And we've got Prasanth, who's been born in Australia. And the question is, if they have been vaccinated, are they still protected? These are the questions. And so the answer, like all things, is going to be a little bit, it depends. But what I can say is that, unfortunately, for little Prasanth, and Prasanth is not breastfed, he is unfortunately not able to receive the typhoid vaccine until he's 2. So doubling up on the food safety advice for his parents is going to be super important. And I would be printing information to help them manage that. But in actual fact, we know that Bindia hasn't really been anywhere during the pandemic, so she's going to need typhoid. And the question for Priya and Nikitha really will be, have you had typhoid in the last 3 years? They've been in Australia for 4 years, so the air may give you the answer to that. And if the answer is in doubt, then you might say, look, we're going to protect you because we want, we want everyone to be protected from this. We will get to cholera at some point. But I'll just stick with the typhoid now and make some suggestions about what kinds of ways you can protect people from typhoid, Salmonella typhi. And really, it comes down to the following. So unfortunately, the youngest that we can start is 2 years old, and that's with the Typhon VI, and that's a single dose, and we're going to be giving that 3 yearly. But the Vivotive capsules are also an option if the family chooses to. And we've got Bindia. She's a young girl. She might be a bit needle phobic. This may be something that the family want to take up. And so that's you've got to do either a 3-dose course or a 4-dose course, depending on whether they think they're going to need ongoing typhoid protection. But for the adults, you can go and just give them the Typhon VI, or this is where you could really think about combining your your vaccines with the Vivaxum. So Vivaxum you can use in people who are aged 16 and over. It's really only going to be an option for the parents, and that'll come down to whether or not you believe that they're Hep A immune or not. So you've got a couple of options there, and you might change your advice depending on, particularly with Bindia, whether you can reduce the injection burden for her by using oral capsules. Unfortunately for typhoid too, you've just got to keep going and boosting the immunity. So this is one of those things, even for very seasoned travellers, you've got to keep coming back and asking yourself this question. The next condition that we're going to go through is hepatitis B. And I'm not going to spend a lot of time on hepatitis B because it is on the NIP. I think that as GPs, we order hepatitis B serology a lot in pregnancy and when we're doing investigating abnormal liver function tests, etc. But I think it is a really important opportunity to check hepatitis status in travellers. If you're of a particular vintage like me, you didn't get it when you were a kid, and so we need to purposefully catch some adults up who haven't received it as children. And then we've also got high-risk populations that we need to protect people from. Now, often what you choose to do here will be based on serology, because again, if we don't know what the parents. I'll just distract myself with Karen Redmond. It doesn't make sense with the Vivaxum. It's because the hepatitis A, you need to give the junior dose. So it's hepatitis A junior and then the typhoid. So that's why the two tend to get split up. So you could say to the family, we need to check your hepatitis serology. We know that if we've got, yes, and you can use it off-label. I do accept that that comment there from Harry. If you, we know that Prasant will have had his hepatitis B updated because he's been tracking the NIP. When it comes to the other members of the family, one of the things that you might need to decide is, well, only if I really think that this family hasn't got their immunity. You can boost them if you choose to, but it may be worthwhile getting the immunity checked because they may prefer not to have to pay for vaccines that they don't need. And coming from India, it is very, very likely that they will have participated in these vaccinations already before they left their home country. But Prasant, we know that for certain because we can check the air for him. So we're going to move on, and just a comment too, because I know that this comes up all the time as health professionals, and we talk about the hepatitis B non-responder. So, for example, if you check the immunity, and Priya and Nikita say, "Oh, look, I've been vaccinated, but now I've got my antibody titers are under 10." That's a really common question. What do I do about a non-responder or a waning immunity? And the answer really is you do a booster after the primary dose, and then you check their immunity 4 weeks later. And of course, you want to make sure they haven't contracted hepatitis B in the meantime. And then if you give a single booster dose and not much happens, that actually happened to me. It was very disappointing. Then what you do is you give another 2 boosters and you separate those by a month. And then you recheck the titers again a month after that. So it means that people can end up having 3, 4, 6 doses of hepatitis B. So for a non-responder, it's primary course. They haven't got antibodies, booster, and then test in 4 weeks. If they're still not seroconverting, you do another 2 boosters separated by a month, and then a test a month later. And that's a lot of exposure to the vaccine. And so generally people accept that there is some protection, even if there isn't seroconversion for people who are not at high occupational risk, for example. So we'll just move on again. And I will also mention MMR. It is recommended for travel to Bali and other places. I'm not going to labour this also because it is part of NIPT and we've only got limited time this evening. But I do want us to remember that even though there are NIP vaccines, that you kind of almost separate in your mind away from the travel consult. A travel consult is an important time to get those other disease states immune and to ask the question, have you been vaccinated twice in your lifetime? Do you have adequate protection? And from Prasant's point of view, have you got the maximum protection that you can have, given that you're still working your way through the program? And so the answer here will be, Prasant is up to date for his age, and you'd only check the immunity if you thought that there was doubt about the other family members. And if you thought, well, look, I think Priya and Nikita, really, we're not sure, you could just give a booster of MMR if you chose to, or you could check immunity. Both of those would be acceptable courses of action. So we're going to now talk about rabies. As you may have gleaned, we've worked our way through things that I think from a clinical reasoning point of view are fairly straightforward. It's very hard for me to think of a reason not to protect people against hepatitis A, B, influenza, MMR, and typhoid. But then the question comes up, well, what about rabies? Rabies is a total catastrophe of a disease. It's almost always fatal, so that is bad. And it occurs in all bats. And in rabies enzootic countries, then some of the land animals can carry rabies as well. And so one of the questions here is, how can we deliver as rational advice to this family about whether they benefit from the rabies vaccines or not? So I'd invite you to put into the chat or on your sheets, what are the kinds of questions I ask myself and the family, rather than just say everybody who goes to Bali, no matter where or for how long, gets rabies. How do you use this vaccine as rationally as possible? And so, yes, the first question that I would ask is, what are the risks? Are you going to go somewhere where, in particular, your children are going to interact with animals? And in many cases, sometimes the best advice that you can give is don't interact with animals, because children tend to get bitten by rabid animals more than adults. They behave more unpredictably, and animals tend to respond badly to the kinds of movements that children make. And so I guess one of the things about rabies is if you give the rabies vaccine, the 3 vaccines before a person travels, you have not precluded the need for treatment if the person gets bitten by a potentially rabid animal. And the guidelines really, as far as the NIP and the Australian guidelines, is there is a strong preference to try and get the post-rabies treatment in Australia, if at all possible, because we know around the world there's actually a shortage of rabies products. So in the first instance, we know that if you're having the 3 vaccines, you get an additional 24 hours in order to get the care that you need, but you still do need post-exposure immunisation to stop the rabies infection. If you've had the 3 vaccines, you don't need the immunoglobulin, which tends to be the product that is most difficult to source when you're traveling in other countries. But there is still the need to do the post-exposure vaccinations, but you need fewer doses. But for a family of 4, having to deal with a potential rabies bite, whether they are vaccinated or not, is going to be an unmitigatable disaster. And so in this case, you ask yourself the question, what are the chances of being exposed? And can you just eliminate those chances where possible? You've got small kids. So do you have to actually go and see the monkeys? And do you have to go near the monkeys? Children, I would argue, and I do counsel, that avoidance is better than vaccination. And the reason for that are the points that I've made there. And so I would be very keen to say make avoidance, but if the family is very risk averse, they may choose to go ahead and do the 3 rabies vaccines for each of the members of the family. If somebody is really good at the internet and wants to go on the internet and check what the cost of that would be, that's an interesting thing to give to the parents because of the issue of financial consent. Although I do really recognise and espouse the merits of not making your medical advice on travel subject to things like cost. You've got to give the right advice and not make assumptions about what people can or are willing to afford. But for this family, given the amount of risk reduction we're offering, rabies vaccination may not be as rational as advice for animal avoidance, given the age of the children. So there's not a clear answer to rabies for this particular trip for this family. If they do decide to go ahead, you can vaccinate each member of the family. There are 2 different options. They're both inactivated vaccines, and they will need 3 doses. And we've got plenty of time to deliver those vaccines because we've got 6 weeks. If Nikitha turned around and said, oh, I'm about to get a job next month working in a lab that deals with bats, then you would say to him, well, you're actually going to also have a booster because you've got an occupational exposure. But for the average traveller who doesn't have ongoing exposure by their occupation, they only need the 3 doses. So occupational exposure and boosters, it's done at 1 year, the booster for the occupational exposure. Then, that would be a separate conversation about the workplace. The mum is, she's contracepted, but yes, you would not give this kind of vaccination if a woman was possibly pregnant, and you would ask for her to wait for a month afterwards before trying to fall pregnant. So I'm also now going to talk about Japanese encephalitis, and this has become a real issue in the last little while because these very naughty mosquitoes have made it all the way down to Victoria. And so we have heard a lot about this. But I think that we need to explain what this is to patients because encephalitis is meaningless. And I think we need to make it clear that this comes from mosquitoes, and 1 in 3 people die of this disease. And if you survive, half of the people who survive will have neurological sequelae. It is a disaster. And so it can be a very serious illness. And so I think we've really got to consider protecting people, but only really if we're offering them protection for the effort. And so when it comes to, I'll just interrupt myself. I'm sorry, team. I'm managing the questions on my own tonight. There's a question. There are more than 3 vaccinations injected without combination. How many vaccinations can the patient take at a time? Actually, there's really no limit because we know, for example, in some of the vaccines we give kids, we put six disease vaccinations into a single vial, and you can use both deltoids, you can use glutes, etc. You've got to separate the injection sites by 2 centimeters. But when you feel like you're delivering a vast amount, my advice is, particularly because you'll often be doing doses over more than 1 day, you can sort of try and develop a schedule where you're trying to even out the injection burden over the course of your vaccine regimen, which can spread out over up to 28 days. So you can negotiate with the patient how many they want to do on any 1 day. But there's no reason, it's not like you max out at, say, 5. There isn't a limit. The immune system will deal with it, but the patient may have a preference. So we've told people about Japanese encephalitis, and then we've got to decide, well, this family is going to Bali. They're going to be beachside, then they're going to go up into the mountains. The rainy season is over. Who's going to get what? And again, I would say that this is about negotiating and risk assessment rather than sort of protocolizing the answer to this question. And so here, again, I'd be taking a really detailed itinerary, and I'd also talk in quite a lot of detail about mosquito protection, and ask, they're beyond probably the season for significant Japanese encephalitis infection in Bali at this time. And they are having a relatively short stay, particularly a short stay where those mosquitoes are active. They're also not in an active season. And they're not really going to big at-risk rural areas. So the area where they're going is, certainly there are mosquitoes, but they're not going to areas where there's a lot of water, rice paddies, those kind of things. So if the family is very risk averse, they would say yes. If not, then they might say, look, we will exercise mosquito precautions. They need to do that for dengue and other viruses, and that may be sufficient for them. Yes, Bali is free of malaria. And there's no vaccine for malaria, but there is prophylaxis in various tablet forms. So that would be a negotiation with the family. If you chose and the family said, yes, look, we are very averse to Japanese encephalitis, then these are the options that you have. Prasanth can be vaccinated against this disease. And you've got basically two options. So you've got the live attenuated and then also an inactivated Japanese encephalitis. And so which one you choose may also have, there may be some bearing on things like the immune status of your patient. For all the members of the family, they could have either of these. In some cases, people prefer just to have a single dose and have it over and done with, and only boost if they're having really ongoing exposure. The Gespect is 2 doses. Some people find that less appealing, but it is inactivated, and that may suit some people and their immunological needs. So I would certainly be having that conversation. I'm not convinced they need the Japanese encephalitis doing what they're doing and the season they're doing it, but the family may say, we want to mitigate all risk where possible, and that's entirely reasonable. When it comes to dengue fever, now dengue fever is a nasty stuff. It's called breakbone fever because of how aggressive it can be with the myalgias and arthralgias and, the temperatures that it causes. And up until recently, there's really been nothing you can do except manage the mosquito risk. I do just really, for interest's sake, want to tell you about the dengue vaccine because it is out there. But I do just want to highlight that the dengue vaccine has got quite limited utility because it does have certain risks associated with it. So the short answer is, if you've never had dengue fever before, you cannot use this vaccine. The only person who we could talk to about it is Priya. But given the type of travel that Priya is doing, given that Priya's health, I would, and the fact that she's going for a short stay, you would be it would be unlikely that giving this vaccine, particularly when there's $700 to $800 per shot for 3 doses, that we're going to actually do much for Priya by giving her this vaccine. So we certainly, you absolutely cannot give it for a person who hasn't had dengue, so it's not going to prevent a first infection. But she's only going for a short while, and you could do more harm than good. So you'd really be thinking about this for a person who got so sick on dengue or hospitalized, and there's a high motivation to prevent that, and there is ongoing and real risk of dengue. That's really what this vaccine is designed to target. There is the yellow fever. There's no yellow fever in Bali. I've purposefully not sent this family on holiday in Africa or South America. And the reason for that is if you do want to be a yellow fever vaccinator, you do need to do the specific yellow fever course, and you have to update that every 3 years. The Australian College of Rural and Remote Medicine are the ones that actually host that. It is free to do the course, but I don't replicate it here because hearing about it from me would not mean you're able to deliver that vaccine. You still have to do that course. So I've left that deliberately off. But if you're interested, go to ACRM website to look that up. So I'm gonna breeze over COVID-19. I didn't even put an explanation in there because I think if we can't explain COVID-19, all is lost. So I will leave that to your good selves. But I will say that when it comes to COVID-19, ATAGI is currently telling us kids of this age don't need to be boosted unless Bindia had some, hematological malignancy, for example. Priya falls into the consider. Nikita is really more in the recommended because he has other risk factors for more severe COVID. And so that's going to be a negotiation. They're all more than 12 months since their last COVID booster, so they may choose to go ahead. I prefer my travellers to be COVID boosted because it's raging. We've got people that we're in the 8th wave and it's on the rise again. But the true letter of the guidelines is consider and recommended in this case. I'm not going to dwell on that because we're COVID saturated, I think, at this point. So we're now going to send the Singh family to India, right? So they've been to Bali. They had a great time. No one got sick. No one touched any monkeys. And now they're going to go to visit India. Gary, yes, tetanus is considered something to boost as well. And for the kids, they will be up to date. For the adults, that would really depend. That they have young children, so it's very likely that both the parents have had their boostrix because Prasanth is 1 year old, but you would never make that assumption and you would check the air, but absolutely tetanus. So they're going to go for 3 months. That's a long chunk of time. They're staying with family. They're not doing a resort experience, etc. And the family happens to own a rice farm in Uttar Pradesh, and it's wet season. So the risk profile for this family has actually changed quite a bit. And I think that we really need to be respectful of the family that's going to do a prolonged family homestay, because in actual fact, risk goes up for travellers, not down. And that is because of things like exposure to food and water that is prepared in a way that is not usual for the traveller. And there are other domestic risks, animals, transport, often more prolonged exposure to circulating mosquitoes. So yes, I'm with you because I'm seeing all of these fantastic responses. So I agree. We've done some good work already because we sent them to Bali, but actually we chose against JE and rabies, and we've got to come back to that conversation, but we've also got to put cholera, TB and varicella on the table. And yes, malaria, although it's not vaccine preventable, that would be part of the wider conversation. So we're going to talk them through these considerations. And by the look of your answers, I think people are very well informed with the different environment for prolonged stay. And so the first thing I'm going to talk about is cholera. Now, cholera is nasty. And despite what we hear from the literature and from the media, it actually can be mild in some cases. But when it is not, when it becomes very aggressive, you can have death rates between 2 and 10% untreated. So that's actually, I think, very high. And if you get sort of a fulminant cholera infection, those rare cases where people can actually succumb within hours because of catastrophic dehydration and metabolic acidosis. So I think that this is the kind of thing that we really need to talk about, because the food safety here. And so when it comes to this family, I think that we need to talk to them really. All of them need to have this discussion. But once again, Prasanth is not of an age where he's going to be able to participate. So mum and dad and their food safety will need some extra care there. But the options, and I'm not sure if you know what kind of options you would use in this situation, but the options that are available basically comes down to duck oral, which can be used in a child as young as Bindia. But when you do use it in a younger child, then you only administer half of that which you dissolve. That's the trick to giving it to younger kids. They need 3 doses, and it's over 1 to 6 weeks each dose. So you could do 1 a week for 3 weeks, or you could spread it over more. It is true that its efficacy is not as good. It's actually probably about 50% efficacious. So it doesn't have a great penetrance, bearing in mind that sometimes with our flu vaccines, that penetrance can vary between 30 and 60%. But it does confer some protection, and this is what you would consider to be high-risk travel. And yes, Karen, it does confer some protection to other infections of the gut. So even though you would explain to them this is not guaranteed protection and it does not preclude the need for food safety, you're trying to mitigate risk where you can with what you have available to you. And this kind of travel, it would be important. It's the same for prolonged stays, or people who are working, healthcare workers, overseas aid workers. We're trying to bring the risk down. Exactly. So cholera, yes. TB, the family that have come from India will be protected. So the Indian immunisation program is all over this. Those 3 will have that, and you can check. They will probably remember having an ulcerating BCG ulcer. But you can send them to have their immunity checked as well. But really, you can be pretty certain that from the Indian health system, they're protected. Children are particularly at risk. It can be very nasty disease. So Prasanth is a big priority here. And so what we're going to have to do is not only tell the parents that Prasanth needs protecting, and they will know that already, but the issue is going to be where does he get his vaccine? So most travel clinics, mine included, we have stopped giving this vaccine. So Prasanth is going to benefit from going to the local immunisation clinic at his paediatric service. In Victoria, the Royal Children's Hospital does it, but all around the country there are immunisation services. And this is going to be a priority for him before he does that trip. So I'm just going to look at a couple of these comments. So we've got some comments here about efficacy with the cholera sort of starting and then starting to drop over time, which is a very reasonable comment. And the use of the MAN2 test, etc., in terms of screening for exposure to TB. Can they do BCG as soon as they land in India? Well, I guess they could, but I would suggest it'd be better for him to have started creating his antibodies before he arrives, because he's going into a high-risk environment. So I would suggest that he should have it before he goes, and that's actually a real priority for him, because he needs to be protected. I would say there's probably no reason to delay, and I think it might be a bit difficult for his parents to guarantee that he's going to get a vaccine as soon as he lands, etc. So I would say avoid that as an option. So they're the main points that I would want to make. I know that there's so many questions, and I may struggle to get through all of them. But I think that some of the comments that I would make also about the logistics of delivering these kind of vaccine schedules is obviously you're going to have to draw up a schedule for each of the family members in turn, and try to deliver those vaccines over a period of time. So you're actually sort of drawing up a schedule based on what you believe that they need. I'm being asked how long is the waiting list for TB vaccination. I would certainly put in my referral that the family, where they're going, when they're going, a bit about the type of travel, because absolutely we know that homestay travels are when you're traveling to stay with family and live in close quarters in particular, that is a high risk. But I don't know if I could comment on what the actual waiting times are. So it would be important to try and get onto that as quickly as possible. And if you are not certain about getting the child in, then most of the immunisation services in paediatric hospitals have an immunisation liaison nurse. And if you call them or email them, then I can certainly speak for Victoria, they will go out of their way to get a child vaccinated before they undertake high risk travel. It is true that some travel clinics still do BCG, so I don't want to suggest that there's only hospital-based services, but you'd need to contact each of the clinics in turn to determine that. Yes, and the last question is about varicella. So we know that from a varicella point of view, you have much better protection if you've had 2 doses. So that's going to be a conversation for the whole family. For the parents, you're probably going to rely on serology for the parents if they can't remember what they've been exposed to. And you probably know a bit about mum already because she's had a pregnancy in Australia. Dad, we would probably need to check the serology. And Bindia may or may not have had her second dose, which is the optional dose. And so varicella is a higher risk where she's going. And so the second dose would be recommended. And for Prasanth, he would just continue to progress through the NIP as he needs to on time. So there were so many amazing questions. This one about, I'll do this last one about pregnant women, and then I'm very sad to have to draw this to a close. With things like typhoid and hepatitis A and pregnancy, if the woman is going to be at higher risk from those diseases because the travel she's going to do is high risk and unavoidable, then you can deliver the vaccines during pregnancy. There's not been any data that suggests that giving those vaccines during pregnancy causes problems in terms of the pregnancy itself. But because there's limited data, the preference is not to give those vaccines in pregnancy unless it's clinically justifiable. So if mum here was going to go and do this kind of a trip and she was pregnant, I would say that is a high enough risk to justify doing the vaccine during pregnancy. And you may want to liaise with her obstetrician, and you also may want to talk to her about the wisdom of travelling to a high risk area when she is pregnant and how long she wants to be overseas and pregnant for. But there are some instances where you can go ahead and the risk of the vaccine is less than the risk of the disease during the travel. And so you're having that risk-benefit conversation. I did see the comment about the TB Gold assay. Yes, the TB Gold serology is available. You'd have to double check what the MBS says on checking serology for travel purposes. I don't want to make any comments about how rebatable it is. Somebody might want to get on the MBS online and just double check that, but that is also certainly a way of checking exposure to tuberculosis vaccination. If just a Bali, would you think that is high risk in terms of things like varicella and varicella? It says consider, whereas India and homestay, I would say that that is a higher risk. So when you look up Bali, it's definitely something to consider, and it's also an opportunity to get people as up to date as possible. But like a vacation in Bali is certainly lower risk than staying for a prolonged period of time with a family in India. I want to thank you all for your participation, because this chat has been going like all blazes. I wish that I could answer all of these questions, but I can't. I would like to say to everyone that you would have the conversation about Bexsero for these kids with the parent as a matter of course. Whether you decide to give it for this kind of visit, that would be up to the parents. I personally would encourage it as an additional vaccine. So yes, we haven't gone through the intricacies of Bexsero tonight, but I think it is a worthwhile comment. And I will have to stop talking now. I can see that Nicole is back online, and I thank you very much for joining me. That hour went way too fast, but I want to thank you for your participation and your amazing comments and questions.
Thank you, Anita. That was amazing. And you did so well to fit that into an hour. That's a lot of information that you fit in there. Thank you so much for your time. It was a fantastic session. We're already getting great feedback saying thank you very much. And we really appreciate your time. So thank you so much, Anita. I have sent out a feedback form to everybody. So if you get a chance, we would really appreciate hearing your feedback about tonight. That would be great. We will make a copy of the recording available to everybody. So if you want to go back over anything you missed, or you'd just like to review again, I will send out a copy of the recording to everybody. And thank you very much to all of you for attending tonight and participating in that great discussion. It was fantastic, and hope you all have a wonderful night. Thank you very much.
Thank you, friends.